Yes, up here in the front.
Sue Bach in Columbia University. It's actually more of a comment, and I would say from the perspective of someone who's been active with the CTSA. One of the things you did not mention was every CTSA has a community engagement resource. Right. And so thinking very importantly of that additional resource, which involves extensive resources and ways of engaging the local communities, and just thinking about how that could be called into play in the NASEM.
Great, thank you for that comment. Question in the back there?
Thanks. Ronan Cooper from Philadelphia. Regarding the F word, do you think that all of the discussions that we've had in the last couple days become theoretical rather than realistic in the context of threatened cuts to public health funding, and the concept that giving flexibility back to states in some way is beneficial rather than maintaining leadership on a federal level?
Great, who wants to take that question? So in essence, I'm going to actually turn to the panel. Who needs money here? And, you know, do you feel that sort of the transitions taking place in public health, you know, are we in a game-changing environment right now fiscally? Greg?
You know, I think your question is very good. And so that funding question is always an issue, and I always want BARDA to pay for everything. I can't get them to do that, but I'm still working on it. No. So, you know, when we talk, though, about flexibility with the states and how does everybody get some skin in the game and that kind of thing, there may be some ways that we could think about doing this differently than just relying on the appropriated monies to the SNS or the appropriated monies to FDA's medical countermeasure program or something. Could we look at, if we wanted to develop something and the states were agreeable that this is something that they really need this information as well, so we have an equal stake in it, maybe there's some way that we could take part of please don't shoot me, anybody, cooperative funding, you know, even if it's $1,000 per state, you know, and say, let's put this into a pool and let's develop something together that meets everybody's need. Maybe there's something that we can do there. Maybe we could look at the various foundations that help support with charitable contributions where the government has capability in a few very strict places to take gift funds. This is something that should be of interest to everybody that might ever need this. Maybe there's a way to leverage some of that. So does it become theoretical simply because we're seeing declining budgetary resources? I don't think it does. But I think what it does is it makes us really think hard about how do you pay for it? How do you advance this capability that we think is critical in that realm?
And let me put my 2 cents into that question as well, which is, you know, going back to my sense of, okay, as in the, you know, even though at times I struggle with remaining optimistic all the time, that, you know, it's that optimism of public health. And I had a discussion yesterday with Carmen about this, which is in essence part of the goal, part of the solutions that we're coming up with this afternoon is in fact a tool to be utilized. And I think we can't just go into the idea of saying, oh, this is all theoretical, it's never going to happen. It goes back to what, you know, John and I had discussed a little while ago, which is, you know, the concept of, you know, okay, let's pretend it's not going to happen, but if it were, right, how is this going to work? How can we use these solutions, in fact, to say, okay, this incredible and esteemed group of individuals gathered together and said, this is what we need. That then becomes a tool for us to push forward and say, hey, listen, it's not just us saying it, it's, you know, the partners out there who say this one. Now, is that going to be achievable? I don't know, right? But I remain optimistic that at some point decisions need to be made. Are we going to get ahead or are we not? That was a panelist in all this. John,
I think we have every reason to be optimistic that we're going to be able to do more based on the technology itself. Every other industry, particularly in the private sector, has actually lowered its cost by using information technology. We've only in the last year did Department of Defense, and then I think it was 2 days ago, the VA announced that they're using off-the-shelf technology rather than plowing billions and billions of more dollars to try to make the two systems talk, which they never could fully do. So as we leverage technology, we should be able to lower costs to deliver more than before. So why can't government do what private industry is already doing, whether you're talking about UPS with just-in-time delivery, or Amazon, or a myriad of private sector retail and distribution networks out there that are doing huge, wonderful things that were not even thought of 10 years ago with a declining base cost on all of those deliverables. So I think we have many reasons to be optimistic about what's going on in the healthcare information space.
You know, Boris, another thing that strikes me here is we're talking about the funding and we're talking about the cost. We don't even know what the cost is. I mean, and so maybe what we need to do is
Well, not only that, we don't know what we want yet.
Don't know the is.
That was my point. Maybe we need to sit down and figure out what are those essential elements of information we must have immediately, and then what are the nice to have, and then what are the really far stretch unicorn information items, and figure out what's out there that might tell us what we already need to know. And maybe we need to look beyond just the healthcare universe. Maybe we should talk to the National Academy of Public Administration. What have other departments and agencies, states and localities done to collect information? Maybe we could ride on the back of some of those things. So I think the funding question is important, but I think we've got to figure out what it is that we have to have so that we can start to figure out what would it cost, and then how can you deal with that funding issue.
Great. Carmen, you had something to add?
And that goes back to, you know, it really then again goes back initially to that ownership or coordination
Right.
question. Who is empowered to be able to do that and pull all the different pieces together where there already exists funding? And so, you know, two things I know. I started out my talk yesterday by saying, I am a nurse. My job is to be the ultimate patient advocate and to make sure that we're all here doing what is right so that that patient can, or that individual can receive what they need, when they need it, and that it doesn't cause more harm and that it helps. That's one thing I know. The second thing I know is we have to be able to ensure that we're doing that whether or not we get additional funding. Additional funding would be great. The more funding you have, the better things and stuff you can do. But that doesn't mean there aren't things and good things that we can do in the absence of a lot of additional funding for this particular space. And that's why I think we have focused on what is already being done, what's already being funded, and how do we connect those things. Because the cost of connecting things that are already being done and the cost of bringing the public health emergency medical countermeasure perspective to that table is much less than trying to retrofit the medical countermeasure piece after the fact or create something entirely new, which you don't do in a public health emergency. And we've heard, you know, you have to be able to do this in day-to-day systems. The other thing that I've gotten very crafty at, and I do appreciate all the funding that BARDA provides. They are incredible in the things that they fund, and we are constantly asking them to fund more and more. And in a way, it's not fair because it is a shared problem and a shared responsibility. That said, I have gotten very crafty at going to additional stakeholders and saying, and the most recent stakeholders being DOD and VA, hey, I have this medical countermeasure conundrum. You have a brand new electronic health system and funding that you have to implement. Let me tell you how my problem is your problem, and how if you fix and use the countermeasure space to help answer some of these questions, you're actually giving yourself capability to answer bigger DOD questions that then I benefit from. So let me help you spend your money. And so I think that's what we're going to have to be looking at going forward and being much more efficient in the way we're looking at what's already being funded and how we make those minor tweaks.
Great. I think we'll have time for one more question. And we can do 2 more. Okay, I'm sorry. Hold on. I just heard something. No, we can do 2 more. Okay, thank you.
Well, this is interesting. I'm John Tigueras with BART, and it's been a pleasure to be a part of this effort for the past couple of years. And I think one thing just to kind of tell everyone in this room is that we have to be really creative because funding is a big challenge. We weren't given a big tranche of funding to start this, which ideally is how you do something like this. So in being creative, I just want to say that one of the ways we can, because if we're going to build this plan, we have to build it, exercise it, and from there refine. You just can't theoretically come up with something and put it on the shelf, and that's going to require time and money. But industry has shown a desire to be part of this, and I think the way we may get to some of this is to do studies with industry, with candidates, that we can generate data that, for example, may be meaningful to BARDA in a specific program, FDA, CDC. It kind of hits all legs of the stool from the government perspective. And from there, just do a study, try to answer some fundamental questions. We don't have to solve the entire plan in the first step, but do something that starts generating key elements of the infrastructure while justifying the use of the funds to generate data for maybe a product in development. And there's an industry partner in this room that was part of those early discussions. So we've got to find a way to creatively take that first step. And if we can't find funding from nowhere, let's try to have low-hanging fruit to accomplish a couple of goals across the agencies and industry and the other stakeholders. So that, to me, is how we get this going. Just wanted to share that. Thank you.
Great. Thank you, John. We have about 3 minutes left, so do we have anyone else who has like a relatively 3-minute question?
I have a 3-minute question. My name is Leah Stone, and I'm from AABB. We are the standard setting and accreditation organization for blood banks and transfusion medicine. And the blood sector has been experiencing some significant challenges, which are currently threatening the sustainability of the blood sector. And one thing that my colleague and I have been discussing is the current lack of interoperability between the EHR and the blood electronic records. And this lack of interoperability limits the ability to understand the real-time status of the blood system, and which in turn makes it impossible to evaluate surge capacity. And while blood is not technically an MCM because it assumes it's going to be there, we're concerned that it may not. So it could be an interesting pilot, I guess, because it's just a smaller, something that's small, it's standard, and just something to consider.
So I do want to make one clarification and under the definition of MCMs, blood and tissue products do fall under that definition. Right. So technically, yes. And we've had a lot of work with regard to blood and blood products in the medical countermeasure space in the response to Zika. So don't count yourself out.
The problem we have, and it's not just blood and blood products, is when you talk about interoperability from an electronic health record, you're talking about many different platforms, different proprietary products, different languages that they use, and that's the big challenge. And what we're working on is we're working with other stakeholders and people like Direct Trust, Commonwealth, to develop by consensus industry standards to communicate. Unfortunately, it's not as simple as it sounds to make one machine talk to another, but we see that as probably our highest priority at ONC, and would love to communicate with you more about that.
Great, thank you, and thank you to all for joining us for this inspiring collective action panel. Next up on the MCM network, the sinking of the Titanic, fault of the ship, the iceberg, or the U.S. government. Thank you.
Or the Rear Admiral.